Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Expert Second Opinion, as tonight our clinical investigator faculty will discuss the role of novel treatment approaches in the patients with follicular lymphoma and diffuse large B-cell lymphoma. We have a great faculty up here on the stage from the far end of the stage, Dr. Matthew Matasar, Dr. John Leonard, Professor Pier, Luigi Zinzani, Dr. Nancy Bartlett, and Dr. Loretta Nastoupil. As always, in all of our programs, we will at times be talking about the use of unapproved agents and regimens, so please check out the package inserts of various products for more information. One of the things we've been doing, particularly since the pandemic, is integrating pre-produced video into live events. We're going to do that again tonight here. I work with several investigators, and I asked them about what they thought would be interesting to talk about tonight. Did they have any cases they thought would be interesting? We have quite a few people. We're doing did videos all day. We're going to be doing them in San Antonio and beyond. And of course, we're working with some great faculty these 2 weeks as well. So let's get into the nitty-gritty of what we're here to talk about. I met with Drs. Casulo, Lunning, and Sen. Each one of them spent an hour and a half with me. I picked their brain about what's going on related to these topics. Did they have any good cases to present? And you'll see them infiltrated through this meeting. So we're going to begin talking about upfront treatment of diffuse large B-cell, and particularly the role of antibody-drug conjugates, of course, polatuzumab vedotin. So Matt, take it away.
Thank you so much, Neil, and good evening, everybody. Nice to kick this off together. So Neil asked me to talk about where we're at in terms of the role for polatuzumab vedotin in the treatment of newly diagnosed large cell lymphoma. So this is an audience that well understands that diffuse large cell lymphoma is the most common aggressive lymphoma in America, makes up about a quarter of all new diagnoses in this country. Of course, we increasingly understand that large cell lymphoma is not a single clinical pathological entity, right? There's a lot of heterogeneity that we lump under the title of large cell lymphoma. And for the longest time, we were talking about cell of origin as a great way to try to split this disease into some different subtypes, germinal center and activated B-cell or non-germinal center. And we've known that the ABC or non-GC patients historically have had a worse prognosis. But there's obviously a lot more sophistication that's coming down the road for all of us as practicing clinicians as we move away from these crude tools and talking about more nuanced molecular classification schemas. And I think that this is going to become increasingly relevant to us over these next years as newer treatments emerge that are subtype specific. A lot of science has been going on, but not a lot of progress. And really the story over the last decades in terms of our approach to the newly diagnosed patient with diffuse large B-cell lymphoma has been one of a lack of success since rituximab, with the important exception of the data from the POLARIX trial establishing the role of polatuzumab vedotin. This little guy here, that's Dolabella auricularia, the Indian Ocean sea slug. You might say auricularia, sounds like auristatin, and this is actually the little critter that we got MMAE from originally. That's the payload in polatuzumab vedotin, this antibody-drug conjugate targeting CD79B on the surface of malignant B cells, delivering this antitubulin payload to the malignant B cell. And the role of polatuzumab in the treatment of newly diagnosed large cell lymphoma was established in the POLARIX trial. This was a globally conducted randomized phase 3 trial in patients with newly diagnosed large cell lymphoma up to age 80 with IPI 2 or greater disease, stratified by IPI and by the presence of epsilon and bulk and by geography to receive either standard of care R-CHOP 6 cycles or substituting vincristine for polatuzumab vedotin at 1.8. There were 2 additional doses of rituximab given to satisfy European regulatory concerns. We don't do that most of the time. And of course, the data from POLARIX originally read out positively for its primary endpoint of progression-free survival benefit, with the hazard ratio originally 0.73, so 27% reduction in the risk of progression or death by substituting vincristine for polatuzumab. Importantly, at first readout, the overall survival showed no benefit with a hazard ratio of 0.94. So PFS benefit without OS benefit. These data, of course, have been subsequently updated with a 5-year update published relatively recently, This hazard ratio has come down a little bit to 0.85, but still with confidence intervals crossing 1, we still say that there is no statistically significant improvement in overall survival, despite our ability to defer or avoid relapse by using POLA. So, of course, the question is the juice worth the squeeze? We learned in the original efforts, looking at polatuzumab in large cell lymphoma, adding it to BR way back when, that certainly there is increased toxicity, particularly neuropathy. In the Polaric study shown on the left, you see that there really is quite superimposable toxicity. These are quite similar in most of our opinions. Indeed, I treated over 30 patients on this study, and it was randomized and double-blinded, and I never really had a sense who was getting what. It really did feel quite similar. There is maybe a little bit of increased GI toxicity, diarrhea particularly, but these toxicity profiles quite similar. Neuropathy is common to both vincristine and polatuzumab. It's important to understand that it's not quite exactly the same neuropathy. They both induce largely a sensory neuropathy, peripheral in nature. There's a little bit of different kinetics, as we showed from the Polarics trial. With vincristine, it really peaks by cycle 6, and then, it stabilizes and then reduces. There is this late cresting phenomenon with polatuzumab neuropathy, where even after the 6th cycle of POLA plus RCHP, there's increased neuropathy for the next following weeks. So it's important to remember when you're using this to not fall behind neuropathy, or it will get ahead of you. In terms of looking at subgroup analyses from Polarics, there's important lessons that we drew from this, and much of this can be summarized as higher risk disease patients derive increased benefit from intensified therapy. And that's true when you look at the IPI scores, which is the 4th bar down. That IPI 3 to 5 derived much clearer benefit than the lower risk IPI 2 patients. There's been a lot of attention given to the cell of origin data, which is the 3rd bar from the bottom, with an apparent suggestion that maybe polatuzumab vedotin is a cell of origin specific treatment, with the ABC patients benefiting and perhaps not the GC, and that requires further exploration. So we went back and we looked at prior use of POLA in earlier trials in the relapsed refractory setting, and maybe there was a little bit of a signal that the GC patients derived less benefit. But remember that we've already talked about the fact that GC is a generally more favorable disease than ABC, so maybe there's some confounding by indication going on here. Importantly, remember that germinal center diffuse large B-cell lymphoma is a myth. There is no such thing. It doesn't exist. And you can divide these germinal center so-called patients by Hans criteria into different biological groups. And one way to do this is on molecular signature into a more aggressive dark zone signature or a less aggressive light zone signature, all of which would be classified by Hans as germinal center. So we went back to Polarics and we looked at this classification and looked in the GC patients who, quote unquote, didn't benefit. And what we saw is that the biologically high-risk germinal center patients, the dark zone signature patients, did derive benefit, right? A hazard ratio that was very clear, 1.61, statistically significant even in that small subset of patients, whereas the biologically less risky patients did fine with R-CHOP alone. What about other ways we can leverage polatuzumab in the first-line setting? One important study that we're waiting for full data readout on is the so-called Polar Bear trial. These names are just excellent. This is looking at the use of polatuzumab in combination with our mini-CHOP in older or frail patients. Recall that Polarics was up to age 80. This is looking at age 80 and beyond, or frail over age 75, using the mini-CHOP backbone in lieu of the full-dose R-CHOP, substituting POLA for vincristine as in Polarics. We don't have the efficacy readout, but we do have early safety readout, and encouragingly, the use of full-dose polatuzumab vedotin in an older and frail patient population was not associated with clear increase in toxicity over the mini-CHOP backbone of dose-reduced vincristine. So my bottom line here, in terms of where we're at with polatuzumab in the first-line setting for diffuse large B-cell lymphoma, I think that the Polarics trial really does establish the POLA RCHP or Polarics regimen as a standard of care, although certainly not the standard of care, in patients of IPI 2 or greater large cell lymphoma. That was the eligible patient population. We see a progression-free survival benefit that is held up with maturation of data without increased toxicity significantly associated with that benefit. The absence of an overall survival benefit does complicate things in terms of defining it as a uniform standard of care, but it's a relevant choice for many patients. There is a little bit of what I call residual uncertainty regarding whether this is a subset-based or biology-based patient selection, whether everybody should be getting the Polarix regimen if they're RPI2+, or should we be picking and choosing based upon different assessments of risk. We're waiting for data from the Polar Bear trial to tell us about its relevance in older patients. I know that many have already adopted this in their routine practice for high-risk elderly patients, satisfied by the safety data in anticipation of efficacy outcomes. And of course, we have a lot of questions that remain in terms of how we should continue to incorporate polatuzumab in the context of what is a rapidly evolving landscape in the first-line context, with many very important clinical trials reading out over the months and years to come, some of which we use a R-CHOP backbone, some of which use a Polarix backbone. So we're going to have a lot of challenges facing us as a community, determining how best to continue to apply polatuzumab as standards of care continue to evolve, hopefully, for the better.
Thanks, Matt. So before we get to Dr. Sen's case, John, could you elaborate a little bit on your experience with polatuzumab in terms of neuropathy, both in the upfront setting as well as the relapse setting? How often you actually have to hold therapy? Is it usually reversible?
Yes, I would say that I've not really noticed a major difference between polatuzumab and vincristine in the setting of R-CHOP. And, occasionally you'll have a patient who you need to hold in a later cycle with each approach, but I would say I haven't really noticed a specific difference in that regard.
So, Pierre, I'd like you to listen to this case that Dr. Sen's going to present of a 58-year-old man who actually presented with testicular swelling, as you're going to hear, and abdominal discomfort, as found to have ABC subtype stage 4 diffuse large B-cell.
He presented with a left testicular mass as well as abdominal discomfort. He underwent an orchiectomy, which demonstrated a diffuse large B-cell lymphoma ABC subtype. Staging revealed a right pelvic sidewall mass, possibly involving bowel, as well as a paravertebral mass at T7 with extension into the lung. So he had stage 4 disease with multiple extranodal sites. Based on this patient's presentation, and I have to say particularly the fact that he was an ABC subtype, we elected to start him on Pola-R-CHP, and he received 6 cycles of therapy and actually received a complete response and did very well on treatment. So the questions I throw out to the faculty are, what frontline treatment would you have started him on based on this scenario? Would you give this gentleman CNS prophylaxis? And if so, what would that prophylaxis be? I think a challenge right now is, do you measure cell of origin in the community setting? My understanding is most centers still rely on immunohistochemistry and the Hans algorithm, and we know that, there's discordance. And the question is, what should physicians be relying on right now? And, do you make decisions based on cell of origin regarding upfront therapy right now? And do you feel comfortable making that decision on immunohistochemistry alone?
So, Pierre, any thoughts about this case?
In our hands, I think it's normal to use Polar-CHP, but at the same time, normally use the local radiotherapy on the contralateral testis. I think is fundamental, because if you don't use this kind of prophylaxis in the next 1 or 2 years, there is again a lymphoma and the contralateral testis. Is fundamental. Don't forget this. And at the same time, it's controversial the use of meningitis prophylaxis, because at the end of the day, it's not a real good prophylaxis, but sometimes we can decide to use 1 or 2 cycles of a high dose of methotrexate at the end of the induction treatment with the Polar-CHP in these cases.
So, Nancy, any comments on this case? What about CNS prophylaxis in a patient like this? And how are you making your decisions about Polar-R-CHP?
So I am using the cell of origin by Hans to make decisions about the POLA R-CHP versus R-CHOP. I think I've seen some of the data in both the relapsed and the upfront setting, and I think it's pretty persuasive in terms of the ABC subtype, or I should say non-GCB, because it's by Hans, and that's the best you can say, is more active POLA is more active in that setting. In terms of the CNS, I think it's a very difficult question. I know we have all these retrospective studies that show there's probably no benefit, but they're all going to have a very, very small population of testicular lymphoma, and so I don't know that we can say there's no benefit for anyone when I think we see things like testicular, renal, adrenal having much higher incidence of CNS relapse. And this particular patient, had other extranodal sites, which would be even a higher risk of CNS relapse. So we have been using both intrathecal methotrexate during the POLA R-CHP cycle, so 1 dose for each cycle, and then giving 2 to 3 doses of high-dose methotrexate at the completion of treatment.
Loretta, you're kind of in a unique position, having worked at MD Anderson and now out in the community. Do you feel comfortable trusting a community-based pathologist to do IHC for cell of origin?
I feel very confident in IHC. I think some of the challenges, as Matt alluded to, how confident are we that the IHC really is picking up those high risk versus low risk? I will say community oncologists do a better job of doing cell-free DNA than we were doing even at MD Anderson. So I'm optimistic that as our tools get better, we may even do a better job of parsing out those high-risk patients. I think as you've heard, we're all comfortable giving POLA in place of vincristine for an ABC subtype, but that's the less frequent scenario we're faced with. And so I remind myself that there were other factors like high IPI that also makes me comfortable replacing vincristine with POLA.
What are you doing about CNS prophylaxis, Loretta?
Again, it's much harder in a community setting where we generally have to use our radiologist to start that LP and then stop what we're doing in clinic, walk over and administer that methotrexate. So I recognize the nuances. I remind myself we're probably treating our anxiety more, but I agree with Nancy in this case. There's a lot of reasons why I would offer probably 2 cycles of high-dose methotrexate.
And also, I like that word offer. It's a theme in oncology. If the patient wants to be involved in a decision when you're not sure, I think that's really an invitation to do that. John, you had some thoughts?
Just one really important point. If you're going to give systemic methotrexate to this patient and you're going to give testicular radiation, you want to do the methotrexate before the radiation because you can get radiation recall, and that's a particularly challenging area for radiation recall, and I've seen that. So you would want it. So if he's had radiation and then you give methotrexate, you can get a very bad skin reaction to the methotrexate. So the idea being methotrexate first, radiation afterwards.
That's a really great point. Matt, what are we looking for in terms of ongoing trials or new approaches in the first-line setting? One thing I see, there's trials looking at BTK inhibitors. Do you see a future there?
There's a lot of exciting data coming forward in the very near future, Neil. We expect to be having readout from a couple important studies even over these next probably 3 to 6 months. One is called the Escalade trial, and that's a randomized trial of R-CHOP with or without acalabrutinib. Lymphoma folks in the audience will remember that Phoenix, which was a trial of R-CHOP plus or minus ibrutinib, was a failure, but in post-hoc subset analysis showed a benefit for patients who were younger with an overall survival benefit in that post-hoc analysis. So this is the Phoenix reborn from the flames and testing acalabrutinib, which is clearly a better tolerated BTK, in patients with ABC subtype as defined by nanostring by an assay. So if that trial reads out favorably, then that test will presumably become a companion diagnostic, and we'll be really talking about cell of origin.
So we're going to move on now and actually talk about CD19-directed monoclonal antibodies, particularly tafasitamab, both for diffuse large B cells as well as follicular. So John, let's talk about it.
Great. So my task, as noted, is to give you some updates on CD19-directed antibodies in large cell and follicular. And pretty much as far as approved agents at this point, we're talking about tafasitamab, which is a humanized CD19 targeting monoclonal antibody. You can see its schema there that's involved in both direct cytotoxicity and NK cell and macrophage immune-mediated mechanisms, both phagocytosis and ADCC. And so basically we have a number of studies suggesting the value of this agent in certain clinical settings. We'll first start with the L-MIND regimen that led to the approval of tafasitamab in combination for a subset of patients with recurrent large cell lymphoma. This took patients that had recurrent disease, large cell lymphoma, 1 to 3 prior regimens, not eligible for high-dose chemotherapy and transplant, and importantly, not primary refractory patients. It was 80 patients. You can see the regimen here, tafasitamab, basically weekly, every 4 weeks. So it's basically 12 weeks of weekly tafasitamab. Then it goes for the rest of the year to every 2 weeks, cycled through lenalidomide 3 out of 4 weeks during that time, and then the option to go on beyond that, again, on the every 2 week schedule with tafasitamab later. So it's a fair amount of tafasitamab. Important here, there's no rituximab in the large cell lymphoma regimen. That's different than follicular that we'll come back to later. And so the key points of the patients, again, remembering this is about 80 patients, half of whom had 1 prior regimen, half of whom had 2 or more prior regimens. Median age was 73, so you'd expect an older patient not being transplant eligible. About half had IPI 3 through 5, and half had 1 prior therapy, half more than that. Although about 43% were refractory to their last treatment, I'm thinking that's mostly the 2 or more prior lines of therapy patients. And the bottom line of this, and this has been updated, was most recently updated last year in Hematologica. The overall response rate in this patient population, 57%. It's 41% CR rate, and the median progression-free survival just under a year, and this has been pretty consistent through all of the analyses that have been reported. This gives you the Kaplan-Meier curves, and again, it's a fair amount of therapy, but on the other hand, there are a significant percentage of these patients that go out. You can see even 2 years, and in some cases 3 and 4 years. It's a little bit better if you had just 1 prior therapy, less favorable, not surprisingly, if you had 2 or more prior therapies, and that's where more of the refractory patients fell, but still some meaningful remissions in this group of patients, again with a median progression-free survival of just around a year. And the overall survival here also pretty reasonable for this patient population. Again, remembering that they were not particularly heavily pretreated, but also older patients who could still do well for several years in many cases. So when you look at the subgroups, and this was not, it's an 80-patient study, so there's only limited numbers of patients in each subgroup, but as you look, really the older and younger patients, bulky disease, a little less good. The cell of origin, a little bit less favorable in the germinal center subtype, interestingly. Most of these overlap, as you can see, and not surprisingly, the more prior therapies and more refractory disease patients did less well, but nonetheless, each group, either favorable or unfavorable, as you look at these plots, still some of these patients could benefit regardless of their prognostic features. That brings us to the Firm-MIND study. All of these have MIND in their name, so I guess if you see MIND, you know it's a tafasitamab study. This is a very similar design of a study, another 80 patients, very similar treatment regimen. You can see across the top here, there were some biopsies performed as part of this study. So this is an ongoing, again, phase 3 study to provide more information in this similar patient population. The eligibility, to my eyes, seemed quite similar to the prior study. Again, not transplant-eligible patients. So that's an ongoing study. And then this, I think, is an interesting study, also ongoing, the MindWay study. The point of this study, it's a similar patient population, but you'll notice here that the dosing is higher. There are a couple different cohorts. The dosing is higher, and my understanding is that the nature of this study is really trying to get the infusion, giving higher doses, trying to get the infusion frequency from the biweekly to the monthly schedule, which is obviously better for the patients if the efficacy and safety is preserved through that. And I think there are a lot of PK analyses and so on that are going on, as well as safety to look at this group of patients. So I would say that this is, I think, important from the patient's perspective to try to cut back on the number of infusions and trips to the doctor if the regimen can be preserved in efficacy and safety. So not surprisingly, like in other venues, regimens that work in the relapse setting are being combined with R-CHOP. This is the first MIND study. This has been reported in the phase 1b study. Most of these patients, these were treatment-naive patients with diffuse large B-cell lymphoma. About 2/3 were over 60. Most of them were IPI 2 and 3. There were two different cohorts here, some just getting tazemetostat plus R-CHOP, some also getting lenalidomide at the 25 milligrams just on days 1 through 10 as part of the regimen, and then weekly tafasitamab all through this approach. And the side effects here you can see, I think, pretty reasonable as far as what we would see with R-CHOP. Main side effects, neutropenia, anemia in the different regimens and approaches and patient populations. Febrile neutropenia being about 18% or so, so perhaps a little bit higher than you'd expect with R-CHOP, but certainly not well out of the range of what might be considered manageable and not atypical. And the other side effects here, again, you can look through the list. The font is small, but mostly GI, some hypokalemia, and other sort of reactions. I think the takeaway here is that most of these non-heme adverse events were under 10% of patients. So this is obviously a relatively small study, but we have data on these patients and the follow-up, again, remembering that most were IPI 2 and 3, an overall response rate in the 80% range, and 2-year progression-free survival being between 70 and 75% or so. So certainly encouraging, certainly also encouraging that the patients could generally tolerate the regimen. And that leads us to the frontMIND study, which is a phase 3 randomized trial that's ongoing, looking at R-CHOP with or without tafasitamab and lenalidomide in the IPI 3 through 5 group of patients. So that's ongoing right now. And then finally, the InMind study, which I'm sure many people have been familiar with. This is an important study. It was a late-breaking abstract a year ago at ASH. And this took patients with recurrent follicular lymphoma with one or more prior regimens, no prior lenalidomide or rituximab. Here it was basically R squared with a placebo versus R squared plus tafasitamab. And you can see it basically mirrored what we had done in the augment regimen, but adding in tafasitamab essentially for 3 months weekly, and then going every 2 weeks for the rest of the year. And this is a group of patients, a big study, 548 patients, mostly advanced stage disease. I think the key takeaways in this group, just over half had one prior regimen, so mostly in first relapse. About a third had POD 24. And this was generally, I would say, pretty well tolerated. Again, toxicities being about 40% neutropenia, grade 3 or 4, some pneumonias in between 5 and 10% of patients, and other side effects, as you can see, remembering that this took place in the course of a lot of COVID infections going on. The lenalidomide discontinuations were similar in about 10 to 15% of patients in both arms across the board, and dose intensity being about 85% in both arms. So it doesn't seem like tafasitamab adds a lot of toxicity to the R-squared combination. And when you look at efficacy here, the overall response rates higher with the triplet, 83% versus 72%. And the progression-free survival was improved 22% versus 22 months versus 13 months overall. And so, again, a positive study with regard to the efficacy endpoints here. When you look at overall survival, quite similar, maybe a hair better with the tafasitamab arm, but not a major difference. And when you look in the POD24 group on the right, whether or not POD24 was present, similar benefits in the two arms. So again, encouraging in these important subgroups. So to wrap up, I just wanted to highlight briefly, there's an abstract being presented by Dual and colleagues at 5515. CD19 expression is preserved following CD19-directed monoclonal antibody therapy with tafasitamab. You can take a look at that. The key takeaway is that you don't seem to lose CD19 expression with tafasitamab, so you can go on to other CD19-directed therapies, presumably in the future, such as CAR T cells. Important information, practical information. And obviously this combination, the tafalen is active in large cell lymphoma, lots of combinations with R-CHOP, benefit when TAF is added to lenalidomide and rituximab. And again, this preservation of CD19 is good news for subsequent therapy. So I'll stop there and we can go on.
So before we get to this case, Pierre, any thoughts about tafasitamab and lenalidomide up front? You have the Frontmind trial in diffuse large B-cell lymphoma that's looking at adding this to R-CHOP. Any thoughts about this strategy, Pierre?
I mean, concerning the frontline treatment, the trial was closed, the accrual of the trial. Do you mean the frontline with TAFA?
Yeah, the ongoing phase 3 trial.
Yeah. The Frontmind was closed. We are waiting for the final analysis, probably at the next ASCO meeting or AHA meeting in 2026.
And what are you anticipating, and any issues in terms of actually delivering the regimen?
I mean, the real problem is that at the end of the day, there are other at least 6 phase 3 trial in the same setting of advanced diffuse B-cell lymphoma. Could be very difficult when at the end of the day, probably in the next 2-3 years, all these will be positive. But the real problem is that if you check, the inclusion-exclusion criteria are the same. IPI from 2 to 5, the age from 18 to 80. The only difference is the escalate, including only ABC, because there is the role of BTK covalent inhibitor of second generation, such as calabutid, and the other one is ZUMA-23, in frontline using only in IPI 4 and 5, using CAR T versus the conventional chemotherapy. It could be difficult to really understand which is the best regimen to use in comparison among this one, Tafalen plus R-CHOP, or the combination of the different CD20, CD3 bispecifics, such as Glofi plus R-CHOP, or Dronextamab plus CHOP without rituximab, or also EPCO plus R-CHOP. This is a real problem for the future, and could be really difficult to understand. I'm not sure for FDA, but for EMA could be difficult to cover all these trial in terms of because they are included in the same subset of patients without any kind of difference in terms of inclusion-exclusion criteria.
All right, let's take a look at a couple cases. And Nancy, maybe you can respond to this case from Dr. Casulo, an 80-year-old woman with diffuse large B-cell who got tafalen.
She's an 80-year-old lady, and she developed this rapidly growing neck mass, which you can see on the PET scan here. And her biopsy showed high-grade B-cell lymphoma. We had a clinical trial where she was able to receive our brentuximab vedotin mini CHP, and she had 6 cycles of that, but ultimately, unfortunately, had primary refractory disease. So I was curious, what would you do in the second line for her with primary refractory disease?
So I see she's doing well on tafasitamab, lenalidomide. Any related questions for your colleagues?
What's the sequence that you use it in if you do? And in this patient's case, the tolerability was fine. There are some cytopenias that we expect was curious how people address that. I'm wondering if you would use TAFA earlier, if it's an option for you for either large cell lymphoma or follicular lymphoma. We know that recent data looked at TAFA R squared compared to R squared in follicular lymphoma, which showed a progression-free survival benefit and an improvement against R squared. So I'd be interested to know what the group thinks about using TAFA earlier in treatment lines or keeping it third line, and for what disease.
So Nancy, any thoughts about this case, and how are you thinking through the use of TAFA-Len and diffuse large B-cell nowadays?
Yeah, so I guess one issue that I have is basically the data from the real-world experience with TAFA-Len, which showed that especially in the primary refractory patients that the response rates were very low, and those patients were not in the registration trial for this. And I think that obviously made the results look better. So I guess I would be a little reluctant to prescribe this for a patient who has rapidly progressive disease or who has primary refractory disease, that I probably would make a different choice.
So also, Loretta, what about the issue of TAFA R squared and follicular lymphoma? How are you thinking that through?
Well, obviously, with the randomized study, we know that TAFA adds in terms of efficacy and not much in terms of safety in relapsed follicular lymphoma. I think the challenges as we see data this weekend with epcoritamab R squared versus R squared is how are we going to navigate that? And so I think it depends on where you practice. I like that John highlighted the data that we'll see this weekend about sequencing, because that's going to become more and more important. And so I don't have as much concern in follicular that I'm going to need a CAR T as I might in the case that Carla just presented in large cell, but it's still reassuring that we're not going to lose that antigen loss. As we see data this weekend where we're seeing these CD20, CD3 bispecifics in frontline, very few relapses, relatively short follow-up, but some of those are CD20 negative. So I think it is nice to have a different target, for instance, with TAFA R squared, if you're going to be moving bispecifics into frontline.
So Matt, maybe you can take a look at this next case here from Dr. Lunning, a 78-year-old man with some chronic renal insufficiency and relapsed diffuse large B-cell. Here's the case.
This is a 78-year-old man with hypertension, paroxysmal AFib, and CKD who presents with multiple purple cutaneous papules. Skin biopsies are diffuse large B-cell lymphoma, the non-GCB subtype, and fishes without MYC or BCL2 rearrangements. PET-CT does identify these multiple avid cutaneous lesions, and they're not within a single radiation port, so they're diffuse. And interestingly, there's no lymphadenopathy. He goes on to get POLA-R-CHP and completes that for 6 cycles, and at the end of treatment, he has a metabolic complete response. Now, 3 years later, darn it, he has evidence of these cutaneous lesions again. He now has a solitary bone lesion, but still no lymphadenopathy. I do the skin biopsy again, and it's diffuse large B-cell lymphoma, same phenotype.
I see she's doing well on tafasitamab lenalidomide. Any questions for the faculty?
He doesn't meet the L-MIND criteria because his creatinine clearance is less than 60. But I think you can give lenalidomide with appropriate dose reduction down to 10 milligrams based upon his CKD and still get the tafasitamab in him. And his best response is a complete metabolic response, and he's still ongoing TAFA every other week and doing quite well. And we got through that first year of lenalidomide exposure, very well with this dose reduction. And so my question to you, Dr. Matasar, is how do you think dose reductions in lenalidomide impacts the activity of TAFA-Len? And also, how do you decide between Lysocell based upon the pilot data versus TAFA-Len based upon the L-MIND data and late relapsing large cell lymphoma?
So, Matt, any thoughts?
Well, thank you, Dr. Lunning. So the points that Dr. Lunning makes about the lenalidomide dosing are super important and super practical, right? This is not multiple myeloma where you can give people high doses of lenalidomide and get away with it. It's something different about lymphoma patients, and we have trouble giving higher doses of len to our patients. Truly, with that creatinine clearance of that 30 to 60 range, most of these patients, even if you try to start them at 20, you're going to end up at 10 and often 5 milligrams. We're very comfortable coming down on that dose based upon tolerance, and we do so expecting that we're not going to be compromising efficacy by doing so. In terms of Dr. Lung's second question about Lysocell versus Tafamine, Tafelen, these are fundamentally, conceptually different approaches. And they're both the right answer, but they're the right answer for different patients. So this is where we get into a shared decision-making mode, where we talk about the pros and the cons of the tools available to us, the potential of CAR T-cell therapy to hold curative power, but the challenges and toxicities that would be associated with that, likely complicated by her comorbidities. What the case as described is somebody who's a candidate for CAR T-cell therapy, but that's an important and nuanced discussion. And a patient may prefer to take a more conservative approach with Tafelen. If there's anybody that's going to benefit from the L-MIND regimen, it's this patient, a late relapse with an indolent relapse who can tolerate a little bit of time for the treatment to work. And I think that Dr. Lenning's choice of the regimen was fully appropriate.
Pier, anything you want to add to that? And how often do you see cutaneous diffuse large B-cell, no lymph nodes, only cutaneous disease? Pierre?
Yeah.
Thinking about it?
Yeah,
he's thinking really hard.
You move to primary cutaneous B-cell lymphoma is a real rare disease, and in particular is represented by follicular lymphoma and marginal zone lymphoma. But at the end of the day, the conventional treatment, if you have only one lesion, is a local radiotherapy. And it's quite common to have a relapse every time in the skin. But if you have several cutaneous lesions, it could be fundamental to try this patient with conventional treatments such as bendamustine rituximab or CVP plus rituximab, no more. I don't think Tafelen could be a good choice for these patients, but the overall survival is quite good. After 8-10 years is roughly 90%, but these patients have a very dynamic situation in terms of up and down with several relapse during the life.
John?
I was just going to say, Nebraska has great pathologists, but this smells a lot like marginal zone lymphoma, the skin, to me, coming back. And so and sometimes extranodally can look like large cell lymphoma, or the cells look large in marginal zone. So I would be a little worried to be so aggressive with such a patient unless, I really had to with just recurrent skin disease. But it smells more like I would have bet if I heard the story and didn't know the histology that it was a marginal zone coming back more than a large cell.
Interesting. Matt?
Yeah.
I think for me the question is the bone disease at relapse that Dr. Lynn described. I'd want to know more about that. Is this a true...
Yeah, it was biopsy positive.
Is this the real deal, or is this a red herring? Because that primary cutaneous large cell lymphoma is a skin disease. It's not large cell lymphoma as we know it, but with involvement of the bone, I think that's a different ball of yarn.
There is also the leg type, but
this doesn't sound like leg type, even leg type non-leg.
Leg type is another disease.
Yes.
Yeah.
Interesting. All right, so Pierre, can we talk a little bit about antibody drug conjugates?
Okay, thank you very much. And my agenda is quite rich. I will start with the Polargo study from a friend of mine, Matt. Polatuzumab vedotin in combination with Gemox plus rituximab in relapsed refractory diffuse B-cell lymphoma. You can see here the study schema of this trial. And after a safety run-in, enrolling 15 patients, the random is 1-to-1 comparing Polar Gemox versus R-Gemox, both of them for 8 cycles. And the primary endpoint of this study was the overall survival. All these patients were relapsed refractory after at least one prior line of treatment and ineligible for allograft transplant. You can see here the baseline characteristic of the 2 study arms. They were well matched, but at the end of the day, we can see that at least 60% of the patients received one prior line of treatment. The remaining 35-40% of the patients received 2 or more than 2 prior line of treatment. At least roughly 58% of all study population were considered primary refractory, all of them diffuse epithelium and OS, and at the same time, there are no real difference in terms of cell of origin. The most part of the patient, of course, were advanced stage. You can see here that the result in terms of the primary endpoint of overall survival was statistically significant advantage of the arm including polatuzumab vedotin, and the same situation also for the progression-free survival. So at the end of the day, the trial was positive. In terms of one of the second endpoint, the efficacy represented by complete metabolic response was roughly 40% with Pola, and at the same time was less than 20% using only R-GEMOX, and the same situation in terms of best response according to the independent center review and investigator assessment. The safety profile, there are no real statistically significant difference. A little bit more toxic in terms of hematological toxicity when you include Pola with R-GEMOX, and concerning the peculiar toxicity of polatuzumab vedotin, I mean the peripheral neuropathy was observed in 4% of the patient grade 3, and for the remaining patient was more than grade 2. The second trial is LOTIS-2. You know very well LOTIS-2. I was involved in this trial. According to this final data, there was official indication of loncastuximab in the setting of relapsed refractory patient with diffuse B-cell lymphoma from the third line. The study population included 145 patients, 95 patients with an age less than 70. The remaining 90 patients were considered elderly with an age of 70 or more than 70. At the end of the day, the overall response rate was roughly 50%, and the CR rate, the complete metabolic response, was close to 25%. And when you compare this data in terms of complete metabolic response with Tafalen or Pola-BR are lower, but at the same time, this single agent is really quite quick to obtain a complete metabolic response, because, as you know, there are an induction treatment with a dose of 150 microgram per kilogram for 2 cycles, and then from the third cycle, the dose is 75 microgram per kilogram, at least for 1 year. And the time to obtain the median time to obtain a complete metabolic response is quite short, no more than 40 days. In fact, in the trial, there were at least 11 patients who received a complete metabolic response after the first 2 cycles, and they moved directly to allostem cell transplantation. These are the duration response cures. There are some difference when you compare the patient according to the age, less than 65 or more than 75, and there is an advantage for the elderly patients. The third trial is LOTIS-7. I am involved also in this. It's Glofi plus loncastuximab in the setting of relapsed refractory patients with diffuse B-cell lymphoma. There are 2 different parts. In the part 1, we included patients who received at least 2 prior lines of treatment. In the second part 2, we included patients who received only 1 prior line of treatment. And the primary endpoint of the study was the safety and tolerability and the MTD. And so far, we included 41 patients, 20 with a dose of 120 microgram per kilogram, and the other 21 with a dose of 150 microgram per kilogram. At the end of the day, the dose of Glofi was 30 milligram. And you can see here is a high-risk study population, including several patients considered primary refractory. And we are in second line. You have to remember that when you have to compare the efficacy with the CAR T-cell in second line. In terms of safety profile, there are the 2 peculiar toxicity related to Glofi, but at the end of the day, in terms of CRS and ICANS, 0 patients grade 3, grade 4, and 5. only few patients with grade 3, 2% for CRS, and no more than 5% for ICANS. And the classic toxicity related to loncastuximine, photosensibility, edema, and the elevation of gamma GT. But this is a fantastic result in terms of efficacy for all the study population of 40 patients available for the response, 87% of complete metabolic response. And the results are quite similar if you compare the patient who received only one prior line of treatment or heavily pretreated patient. The other, to conclude the story of loncastuximine tesirine, there are some preliminary data also in relapsed refractory patient with follicular lymphoma presented at the last ASH meeting, but also published recently by the University of Miami, Alderuccio and co-workers. You can see the study schema, the combination lonca plus rituximab with no more than 8 final courses of combination of lonca plus rituximab. So far they included 39 patients, but also in this case at least 50% of the patients were refractory to the last treatment, and at least 50% of these patients received 2 or more than 2 lines of treatment. These are really interesting preliminary data concerning the CR rate was 85% in POD24 patients, and also in high-risk FLIPI scores, the CR rate was close to 70%. And all the study population data in terms of efficacy, 84% of complete metabolic response, and the overall response rate is close to 100%. Very interesting also the progression-free survival curves. Of course, we need a longer follow-up, but at roughly 3 years, there is a plateau at 72%. The last, but not the least, is the ECHELON-3, the inclusion of brentuximab vedotin again in the ward of relapsed refractory patient with diffuse B-cell lymphoma. These are the data published recently by Nancy Bartlett on JCO. You can see here the study schema. We included the patients with relapsed refractory diffuse B-cell lymphoma who received at least 2 prior lines of treatment, and at the same time the ratio was 1-to-1 comparing BV plus len plus R square. The dose of brentuximab vedotin was 1.2 milligram per kilogram intravenous every 3 weeks, and the dose of LENA was 20 milligram, and the conventional dose of rituximab versus the placebo plus R square. The primary endpoint of the study was overall survival in the ITT population, and also there was a very interesting stratification of the patient according to the CD30 status, with 1% or more than 1% versus less than 1%. It's difficult to define less than 1%. Anyway, these are the baseline characteristics of the 2 study arms. There are no statistically significant differences, are very well matched. In particular, at least 20% of the patients were considered old patient with an age of 80 or more than 80 years. And the median number of prior treatment was 3 for both arms. And in terms of CD30 status, at least 30% of the patient had a percentage of CD30 of more than 1%, and 70%, in 70%, the CD30 percentage was less than 1%. And you can see here the curve, the overall survival, the progression-free survival. There is a statistically significant advantage for the combination of BV plus R square when you compare with placebo plus R square. In particular, the median overall survival for BV containing regimen was close to 14 months versus only 8.5 months for the placebo plus R square. The same situation for the median progression-free survival was 4.2 for BV plus R square, only less than 3%, for placebo plus layer square, 3 months, I'm sorry. And, but I think it's very important to see the efficacy. And on the old study population, the CR rate was 40% for BV plus R square versus only 18.6% for R square. And the situation is quite interesting if you compare CD30 negative, I mean less than 1% of 41% of complete metabolic response for BV plus R square versus only 15% versus placebo plus R square. And the same situation for the status of CD30 of 1 or more than 1%, close to 39% for BV plus R square versus 26% for R square. I mean, the toxicity is a classical hematological and extrahematological toxicity. In particular, you can have some neurological, peripheral neurological toxicity related to the use of brentuximab vedotin in this arm, including BV plus R square. But at the end of the day, according to this data, there was the official indication by FDA concerning the role of Echelon 3 in the setting of relapsed refractory patients with diffuse B-cell lymphoma starting from the third line. Take-home message, Polar GEMOX severely improve outcome, including a 40% reduction in relative risk of death compared with the conventional GEMOX in patients with transplant-ineligible relapsed refractory diffuse B-cell lymphoma. The POLARGO study reinforced the benefit of combining POLA with conventional chemotherapy in the treatment of diffuse B-cell lymphoma. Concerning the loncastuximab studies, loncastuximab-based combination are demonstrating encouraging efficacy in second line, including not only diffuse B-cell lymphoma de novo, but also high-grade B-cell lymphoma, and in particular in combination with glofitamab. You remember 85% of complete metabolic response. Similar encouraging results are observed also in combination with rituximab in a second line for relapsed refractory follicular lymphoma. And finally, concerning the data of Echelon 3, BV has modest activity, as you know, in relapsed refractory diffuse B-cell lymphoma when used in monotherapy, with no clear association with the CD30 expression. But the combination of BV plus R square increased the efficacy independently by the COO, the cell of origin, and also independently by the CD30 status. And this new regimen, BV plus R square, improved survival versus the conventional square, and is a reasonable choice in CAR-T and bispecific failed or ineligible and inaccessible. Thank you very much for your attention.
So before we get to our first case, Loretta, I'm just kind of curious, what are your thoughts about the LOTIS-7 glofitamab plus Lonca-T? Is that something you'd like to be able to use right now, and in what situations? Also curious about Lonca-T and FL. Again, something you'd like to be, are you using it? Would you like to be able to use it?
I think the advantage of an antibody-drug conjugate is it probably gives you some disease stability more rapid. Because a lot of these CD20, CD3 bispecifics, you have to ramp up. And particularly in large cell lymphoma, you may not get to your most effective dose for a couple weeks. And so I do like the combination strategies with these antibody-drug conjugates because the toxicity is pretty well manageable and it potentially will give you a better disease control. I think in follicular lymphoma, and I'll spend a lot of time talking about how complicated it's getting with all the number of drugs, I don't think I have as much concern about getting control of disease as rapidly as I do in large cell lymphoma, and so there's probably less of a role in that disease state.
So, Matt, Carla has a 69-year-old woman with a relapsed diffuse large B-cell. You'll hear she got Pola-BR and then Lonca-T, but it developed a skin rash. Here's the case.
She presented to me with bilateral lower extremity edema, severe abdominal pain, and we diagnosed her with recurrent large cell lymphoma, presumably of the same clone as the first one. She really wasn't interested in aggressive treatments with salvage chemotherapy and transplant, which she would have been eligible for given her late recurrence. And so we decided to treat her with polatuzumab, bendamustine, rituximab. She did have a complete response after 6 cycles of treatment. Unfortunately, she recurred after her treatment, and we found the same large cell lymphoma. So at that time, I started her on Lonca-T, and she had 4 cycles with some partial metabolic response, and clinically her abdomen improved in terms of the abdominal girth, but she had a severe rash that took her some time to resolve. I'd just be curious to see what would people use third line. I think it's important to understand and be prepared for a high use of steroids for patients on Lonca-T. They also do better when you give them diuretics. So Lasix, and in some cases spironolactone, is very helpful at mitigating the edema. And that could be pulmonary edema, it could be ascites, it could be lower extremity edema. I'm curious what your experience is with Lonca-T, how frequently you go to it as an agent in large cell lymphoma, and would you use it in earlier lines? And there's some data coming out using Lonca-T in follicular lymphoma as well, so I'd be interested to see what the panel thinks about that.
So Matt, what's your experience with Lonca-T, particularly in terms of tolerability? Any thoughts about this case?
Yeah, so certainly, Lonca is a very attractive option in a lot of different clinical contexts. It's a 30-minute infusion every 3 weeks. It's time-limited therapy. It's very appropriate for outpatient settings, community settings, as well as academic. So there's a lot to argue in favor of its use. Getting some comfort with managing the toxicities, of course, is important to feeling comfortable prescribing it to your patients. And Dr. Casulo highlighted some of the key toxicities that we're aware of with use of loncastuximab tesirine. In terms of rashes, there's really 3 different types of skin things to be aware of with Lonca. The first is that it is photosensitizing. Dr. Casulo practices in Rochester. Not a big problem. In other parts of the country, a problem. So you really need to counsel your patients about sunscreen. It can be sunlight coming through windows. It's UVA and UVB sensitizing, so they need to cover up and wear sunscreen. The second is a rare but quite disfiguring telangiectatic rash. I've only seen it once in my own practice, but be aware that that's something that can happen. It can happen even after treatment's been discontinued. Referring to dermatology and asking for their help has been my standard approach. And then there's the typical drug rash issues that can happen with anything that we do that tend to be steroid sensitive, and may not recur after a holiday and retreatment. Carla also highlighted the importance of managing fluids, and we know that fluid accumulation is an on-target toxicity that can be seen with use of Lonca related to its tesirine payload. And she very accurately pointed out that we like to use spironolactone or aldactone even prophylactically. If patients have a little bit of baseline edema, small pleural effusions, I will routinely start aldactone preemptively to try to mitigate the risk of further fluid accumulation.
Pierre, anything you want to add to that in terms of your clinical experience with Lonca-T?
Yeah, it's the skin toxicity is a real problem for loncastuximab. I mean, Lonca, as I said before, is really a fantastic drug because when it's active in the first 2-3 cycles, you can obtain sometimes also complete metabolic response. The real problem is this photosensibility. And also in the LOTIS-2 study, the median number of administration of loncastuximab was no more than 7. And in the same trial, LOTIS-7, the ongoing trial, using in combination with glofitamab, the situation is fantastic until the first 4 cycle of Lonca, and then you can observe some skin toxicity that is difficult to really understand which kind of histology, but is related, is a peculiar skin toxicity of this drug, I think, at the end of the day. And it's so difficult to continue after 4 or 5 administration of Lonca, but I think it's important to try in the future when you have to decide some clinical trial or a new regimen, including Lonca, to reduce at no more than 4 or 5 administration of Lonca, to have the best in terms of efficacy, reducing this particular important toxicity.
Interesting. All right, so Nancy, Matt has a 41-year-old woman, multi-regimen relapse GCB, diffuse large B-cell, gets Lonca-T, and then gets BV R squared. Here's the case.
How are you advising your patients who are getting LONCA to avoid getting that, what appears to be sun or UV associated rash? Also, how are you monitoring for the liver impact that can happen with LONCA T? And how are you talking to your patients about the DEX prophylaxis? For instance, I find the DEX prophylaxis to be very important in regards to the management or mitigation of the PBD dimer payload impact, to the point where I feel it's important to discuss it as LONCA T DEX to my patients to ensure that they know that the dexamethasone is complicit with getting the LONCA T.
So I see she ended up with disease progression on LONCA T, and biopsy showed CD30 expression, and she's now on brentuximab plus R squared.
So because the patient had not seen lenalidomide and BV still was now approved based on echelon 3, I did consider in this situation giving BV R squared, understanding that she was rituximab refractory. Are you looking for CD30 status based upon the echelon 3 study, or you believe that CD30, really shouldn't necessarily need to be tested for in order to use it in relapsed refractory large B-cell lymphoma? And then I guess if previously exposed to polatuzumab, will you consider a BV regimen given that they have the same MMAE warhead? Where I'd love to see a lot more data is with LONCA plus GlowFit in the super refractory population.
So, Nancy, I don't know how often you see CD30 negative diffuse large B-cell. It kind of reminds me next week we're going to talk about TDXD and breast cancer. Now they've given up. Everybody's got a little bit of HER2. Do these patients all have a little bit of CD30, and really you see
No,
zero?
I don't think so, because at least in the study, they were willing to accept as little as 1%, and it was 35% positive and 65% negative. So, which is kind of what we've thought from the beginning, that maybe 20 to 30% of DLBCLs are CD30 positive. And I don't have a good explanation for why the CD30s are negative CD30s are responding, other than there's been lots of theories about is it possible that the CD30 is actually treating another CD30 positive, activated T cell or something in the background that's helping, or is there some synergy between the BV and the LEN, which I think we've seen in other settings, like in Hodgkin's with BV-Nivo, that there is synergy, some sort of immune synergy, if you will. So I think that's a possibility. And I guess the other thing that Matt was asking about the LONCA patient, which I just wanted to comment on my own experience, that we were involved with the very first LONCA studies where they were giving, continuously high dose and not decreasing after 2, and not using all the DEX pre-meds, and it was a whole different situation. I mean, everyone got that fluid retention and bad rashes, but I think with their current approval and the current doses, if you give the 2 and you go down and you're very religious about giving the DEX the day before, the day of, and the day after, that we really have seen a marked decrease in the fluid retention and the rash. I forget who mentioned the 3 different rashes, I think Matt, but in the very early studies, we saw so much of that telangiectasia rash, which is permanent. That is, they have that forever. And, thankfully, most of those patients realized that they had sort of a last-ditch effort with this, and they're just happy to be there and can put up with that. And the sun stuff is very difficult, and, I have a few farmers, and you just can't keep them out of the sun, and you can't keep them covered. But if somebody can stay covered, I think it's a better choice.
What about Matt's question about using BV in patients who've had prior POLA?
Yeah, I think that's a great question. When we did that study, very few, POLA was not approved for the first line, so we probably had very few, if any, POLA patients on that study. But I agree. I'm not sure it makes much sense if you're really thinking the payload is the active treatment for the patient. I guess you could justify it from the standpoint of the CD30 negative, that maybe it isn't the payload, maybe there's some other interaction between it. But I guess I would definitely put it lower on the list if a patient has seen POLA.
Loretta, any thoughts about BVR squared? How do you integrate that into your practice?
I I think, as we saw in the study, most of these patients are going to have already progressed following CAR T. They're probably already going to be progressing following a CD20, CD3 bispecific. It's something that's readily available in a community practice, and so I think there are some potential positives there. It doesn't seem to matter about cell of origin, CD30, again, to very low levels, you still seem to get a response. So I think there's a potential role for it, but it's going to be late in the list of things for me.
All right, so we're going to move on now, talk about bispecifics. We'll start out with diffuse large B-cell, and Nancy.
Thanks very much for asking me to introduce this topic for the talk. But so I'm just having 4 different sections, was given these specific questions to answer, which are the pharmacologic similarities and differences among the approved CD20, CD30 bispecific antibodies. So in terms of the similarities, all 4 of the approved antibodies have the same mechanism of action in that they have CD20 and CD3 binding sites, and the effect is to, hopefully what you're doing is binding both the lymphoma and the T cells at the same time, leading to hopefully death of the lymphoma cell. In terms of the half-life and the pharmacokinetics, that all 4 agents have long half-lives ranging anywhere from 6 to 14 days, so I would consider those similar in this situation. And the clearance of these antibodies is very similar to the way we clear natural IgG antibodies, and all of the antibodies have been engineered to sort of prevent rapid degradation by altering the FC receptor. And so you don't also have to worry at all about renal or hepatic dysfunction with these. They all incorporate weekly or twice weekly step-up dosing, and they all require Dex pre-med during cycle 1. In terms of the differences, on the left are the sort of cartoons of the antibodies, and the one that is different is glofitamab, which has 2 CD20 binding sites as opposed to the other 3, which all have one CD20 binding site. And that was important in the early studies. They saw a fairly high incidence of high-grade CRS when they gave glofitamab, presumably related to the fact that they had 2 CD20 binding sites. So those patients all now require pre-med, or I should say pre-treatment with obinutuzumab. Currently, it's about 7 days before the glofitamab in all of their studies. I think they are trying to do some studies looking at a shorter interval so that the patient can get on to the active therapy more quickly. And then in the table, in terms of the other differences, the CD20 epitope, so where their binding is different for the agent. So glofitamab is binding to the same CD20 epitope as obinutuzumab, Epcor and Odro to OFA. And Mosun, importantly, has the same CD20 epitope binding site as rituximab. And that's important in terms of thinking about combinations with these drugs. So particularly Rituxan combinations. So you'll see a lot of the Glofit and EPCO studies include rituximab in the regimen. And that makes sense because they're not going to be having competition at the binding site with rituximab, but you're probably not going to see any Rituxan-Mosun combinations. In terms of the way they're administered, EPCO is currently the only one that is approved sub-Q. Both Mosun and Odro, they're working on sub-Q formulations for those. And the difference there is going to be that with the sub-Q, the peak level is about somewhere between 2 and 3 days after the administration. So you have to give longer Dex to cover for the CRS in that situation. With the IV, the peak is about 6 hours, and so you're going to see the CRS much earlier. In terms of the schedules, Glofit and Mosun have very similar schedules. During cycle 1, they get the step up, and then they're every 3 weeks, and they have fixed duration. And the EPCO and Odro have the step-up dosing in cycle 1, but then continue with weekly dosing for anywhere from 3 to 4 months, and then go to every other week. And both of those initial studies were designed to continue the treatment until either intolerance or progression. So then moving on to the efficacy and safety outcomes from the pivotal registration studies for Glofit and EPCO and relapsed DLBCL, that both EPCO and Glofit are approved by both the FDA and the European Union, and Odro is also approved by the EU, but not by the FDA yet, still working on that. And so I think the important efficacy endpoint is CR rate, because we all know that getting a PR with DLBCL is probably not very helpful, and we know with the bispecifics that the PRs are not durable. So both EPCO and Glofit had a CR rate of about 40%. And then the other relevant sort of efficacy endpoints would be how long those CRs are lasting. And about half of the patients who achieve a CR with both Glofit and EPCO are still in remission anywhere from 2 to 3 years after the treatment. And so I think that's an important endpoint. I don't think it's quite long enough yet, if you will, in terms of saying that we've cured those patients. And then, of course, the most important endpoint for efficacy in terms of the overall population would be the PFS. So this shows the PFS curves for EPCO on the left and Glofit on the right. And it looks like, I don't know, I think maybe a plateau somewhere around 20% for those, which would be about half of the 40% who get a CR. And then below that are the duration of complete remission curves. So at 2 years with Glofit, about 64% of the patients who had a CR were still in CR. And that was actually for EPCO. For Glofit, it's about 56% at 2 years. In terms of the toxicities with these drugs, encouragingly, that very low rates of high-grade CRS or neurotoxicity. So about half the patients getting Glofit and EPCO will have some CRS, but the incidence of grade 3 or higher is quite low. And about a quarter of the patients in these studies received at least one dose of tocilizumab, and they all had Dex pre-meds during cycle 1. And then the thing that I think has become quite apparent to all of us using these drugs over time is that the grade 3 infections were quite high in these registration studies, and I think remain high in our standard of care use of these drugs. And they all of these trials were done sort of during the peak of the COVID pandemic, so a lot of it was COVID. But even so, with the very few fatal COVID infections, we still see a lot of patients getting these who have very prolonged viral infections. And it's, a difficult thing for a patient to have a sort of very bad cough for 4 months in terms of their quality of life and sort of disruption. So I think it's still something we need to think about and work on. In terms of the actual fatal complications in these registration studies that were non-lymphoma related, 4% on EPCO and 7% on Glofit. And as you can see, there were a fair number of COVID deaths on all of these studies, some other infections as well. So how about bispecific antibodies in combination? We've just seen that the single agents have a pretty low chance of curing a patient. So could we do better if we're combining the bispecific antibodies with other therapies? And how about using it in earlier settings in DLBCL, because the approvals are in third line or later? So this table summarizes some of the large phase 2 and 3 studies. I'm going to talk a little bit more about each of these, primarily the STARGLO and the SUNMO, which are the phase 3. But as you can see from the column that talks about the CRs, that the CR rates with these combinations do appear to be higher than what we saw with the single agents. So first starting with the phase 3 STARGLO study, which was Glofit GemOx versus R-GemOx in second line or later. So this is 1 line earlier than the single agents are approved for. And you can see that the median progression-free survival was significantly higher in the Glofit GemOx, so 13.8 months versus 3.6 months. And also interesting to look at the tail of the Glofit GemOx trial, our study, and it looks very similar to what we were seeing with CAR-Ts in terms of that plateau is about 40%. The other thing that came out of this study was that the efficacy was actually quite different between the geographic regions, with the sort of Asia Pacific and Australia, which was almost 60% of the patients in the study, had a hazard ratio of 0.27 in favor of GlowFit, whereas neither the European subset or the very small North American subset, which was only 25 patients, had significant hazard ratios in favor of GlowFit. And in fact, with the U.S. population, it was, again, only 25 patients, so we're talking very tiny numbers in each of the arms. So, but the hazard ratio went the opposite direction. In terms of the overall survival, again, highly favored the GlowFit arm, 25 months versus 13 months. And in terms of the toxicity, there were more serious infections and fatal infections in the GlowFit GemOx arm compared to our GemOx. And I just put there on the right that the FDA did not approve this combination in the U.S. Because of the small number of patients. 9% of the study population was from the U.S. And I don't know whether the hazard ratio going the wrong direction also swayed them. This is approved by the European Commission and has been added to the NCCN guidelines. So you can get this combination for your patients. We've really had no pushback from the insurers because it's on the NCCN guidelines. Then moving on to the second phase 3 study, which is SUNMO, which is Mosun plus Pola, and it had exactly the same patient population as the StarGlow and had the same control arm. So median PFS 11.5 versus 3.8 months for the Mosun Pola. And in terms of the toxicity, as opposed to the GlowFit GemOx, there was not an increase in the risk of serious infections or deaths. So then a couple more phase 2 studies, which were just recently published. So this one in JCO, about a 130 patient study of GlowFit Pola in same group of patients with a 24-month PFS of 42%. And the toxicities here looked very similar to the GlowFit GemOx. And then finally, the EPCO GemOx. Same group of patients. And I put this up because they actually presented their data in terms of prior lines of therapy. So the green curve is all the patients with a 12-month PFS of 44%. The blue curve is the patients who had had only one prior line of therapy with a 12-month PFS of 63%. And the red are the patients who had 2 or more prior lines of therapy. And the publication for the GlowFit GemOx actually didn't give the discrete numbers like this, but did indicate that patients who had had only one prior line of therapy had better outcomes than those with more therapy. So then just to look at the combinations that have been published in first line, so no phase 3 studies in this situation, that they're all small phase 2 studies. And so we're going to definitely need phase 3 studies in this setting to draw any conclusions. I think what these phase 2 studies did conclude was that the addition of bispecific antibodies did not compromise the chemotherapy doses in frontline therapy, and that the CRS rates were of lower grade and less frequent than with the single agent studies. I did put the Mosun Pola chip versus our Pola chip was the only randomized phase 2 study, again, not powered to look at efficacy, but if you look at those CR rates and the PFS, they actually favor the standard arm. So I'm not sure whether this small study will be enough to sort of dissuade them from looking at that particular combination in the future. And then the ongoing phase 3 studies of bispecifics in combination with other therapies in earlier settings. So just 2 slides here. One is with the second line or later, so relapse and refractory DLBCL. There's 3 ongoing phase 3 studies. And the first 2 are with EPCO, I think, just trying to make it into the second line in the same place where the GlowFit GemOx and the Mosun Pola will be. And then there's also one with Odro in that setting. And then in first line, I think everybody's aware of these 3 studies, 2 of which have been completed. Actually, that got off track there. So the ones that have been completed are the top 2, the EPCO R-CHOP versus R-CHOP, and the GlowFit Pola R-CHIP versus Pola R-CHIP, so the SkyGlow and the EPCOR study. And all 3 of the studies have the same eligibility in terms of IPI 2 to 5, and they all limited the number of IPI2 patients to about 30% of their population, which I think was quite important because the patients with IPI2 actually still have a pretty good prognosis. So, and that's it. Thanks.
Thank you. So, John, I'd like you to listen to this case from Dr. Sen of a 66-year-old man who actually got CAR T for an early relapse and then glofitamab.
Based on the fact that he relapsed within 12 months of his initial therapy, he actually went on to receive CAR T-cell therapy with axicabtagene. And although he achieved a PR on PET scan at 3 months, unfortunately, re-imaging at 6 months documented that he had progressive disease. So the question is, what do you do now? We did elect to put him on glofitamab, but I'm curious to hear from the faculty. Is there ever a patient where you would consider using a bispecific antibody ahead of CAR T-cell therapy if a patient was considered, eligible for both? The other question I have is, if you were going to go to a bispecific for diffuse large B-cell lymphoma, we know that both glofitamab and epcoritamab have been approved in the U.S. We've got odronextamab approved in other places worldwide. Do you have a preferred bispecific antibody that you would use for diffuse large B-cell lymphoma, and why?
So, John, sequencing a CAR T and bispecifics in diffuse large B-cell, and which bispecific?
Well, you gave me the very simple question here, so thank you. So I'll just add for the patient she referenced who had a PR following the bispecific. Following the CAR T, there's an ongoing intergroup study looking at a couple different combinations, most and POLA in combination, for those PR patients. So there is a study, if you do have a patient that got a CAR T and doesn't achieve a CR, there is a national study available. And that I think is an interesting question for this patient if that had been available at that particular point in time. So I think, that it's an interesting issue of timing here, right? Because the CAR Ts came along first, and we've seen long remissions and presumed cures in a meaningful fraction, maybe a third of patients with recurrent diffuse large B-cell lymphoma. And then we see the bispecifics, different patient populations, and some long remissions, but not as long follow-up. So I think it's hard to suddenly go to a bispecific most of the time when you think you're curing the patient. You could with a CAR T. I think, on the one hand, you could say, well, a patient who had a late relapse or a patient who had, better disease or something like that, that might be a person that you could use a less aggressive therapy, but that's probably the person who's going to be more curable with a CAR T. So I think it's really hard to say unless the patient has comorbidities or really doesn't want to do CAR T. I think it's really hard to go with a bispecific first. That said, the combinations that Nancy referred to in particular, they are approaching what we see in CAR Ts in some cases. And so I think at some point, you could ask the question, CAR T followed by bispecific if needed versus bispecific followed by CAR T if needed with an overall survival kind of endpoint. And I would love to see that study because that would answer the question. But the problem or the good thing is that both bispecifics are getting better with the combinations, and then we have newer CAR Ts that might be getting better. And so it's really hard to say. The bispecific question in which one to choose, I think, is one that really comes down to a couple practical issues. The epcoritamab is subcutaneous. That might be a little more convenient, particularly in treating the patient, and then the time when you have to admit the patient for hospitalization. There are some practical issues around that. But there are more infusions. And I think one advantage of epcoritamab is that you can use it for both follicular and large cell. And if you don't do this very often, being able to use one drug more often is probably easier to figure it out for somebody in practice. But I think either one is reasonable, and we talk about it with patients. I think it's really going to come down to the practical issues for most people.
So, Pierre, I'm curious also about, in terms of choice of bispecific and diffuse large B-cell, where do you think odronextamab would fit in if we had it available, odronextamab?
Ooh, odronextamab. I mean, at the end of the day, so far I used only in marginal zone lymphoma relapsed refractory patient because it's quite interesting. There are no alternative with the other two, CD20, CD3, but I think that at the end of the day, Glofi and EPCO are superior than odronextamab on the basis of the three different clinical trials, so in terms of complete metabolic response and also in terms of better safety profile, because during the trial the odronextamab changed 2 times the step-up dose because there were a very important toxicity, in particular the ICANS percentage more than 3 grade 3 or more than 3. So at the end of the day, EPCO or Glofi. But I think I have a question concerning what to do when there is a CAR-T failure before to move to bispecific. I think it's fundamental to do a biopsy because in our hands, but also I think everybody tests this, in at least 25%, 30% of the patients there is a CD20 loss. And this is fundamental to try to use in this setting of patient a real drug with a good target. I mean, we have to move to CD19 or something more. Why not brentuximab vedotin? In some situation, we had patients with a very important positivity for this CD30, or why not for checkpoint inhibitors?
Great point. So, Loretta, I'd like you to listen to this case from Dr. Lunning, a 68-year-old man, type 2 diabetes, CHF, COPD, requiring oxygen. Just keep that in mind in terms of eligibility for CAR-T. But he actually ends up getting glofitamab after Glofit-Gemox. Here's the case.
So what did I think about doing with this patient? Well, we have consideration of inpatient Gemox because he was symptomatic. I did choose to do step-up dosing shortly thereafter. I was really transitioning to Glofit-Gemox for 2 further cycles, and he obtained a metabolic CR. But he was really struggling with the Gemox portion, likely because of his other comorbidities, but we were able to get him through that. And he did start to improve when I switched to just Glofit monotherapy for the next 9 cycles, to the point where a lot of his comorbidities had actually improved and he was no longer requiring oxygen at night. So it should be noted that interval PET CTs, again, showed a metabolic complete response. By clonoSEQ, he had no residual detectable sequences, and he continues on active surveillance with interval imaging. I think that this would be a great question for Dr. Nastoupil, being that she's a community oncologist with a substantial amount of CAR T-cell experience. What I really struggle with are patients that are on the fringes based upon comorbidities of whether or not they should get a Glofit-Gemox type approach to get the disease under control, or you could just give them Gemox and get them to a CAR T-cell center, because arguably, I think the things that make this CAR T-cell ineligible is COPD requiring oxygen.
Any thoughts, Loretta?
Well, lots of thoughts. I think in general, so I do think that the combination strategies by adding chemotherapy into a bispecific antibody is going to give you disease control, and it's going to help you get them through that step-up dosing, and you're going to mitigate some of the CRS. I worry a little bit about this patient tolerating glofitamab, probably as much as they would tolerate Lysocell. But I do think that there's a strategy in debulking the disease with the chemotherapy and then carrying through. I think he highlighted a couple of points. How much benefit do you get from chemotherapy after the first 2 cycles, particularly with oxaliplatin, where you're going to have peripheral neuropathy? He talked about cell-free DNA. Sounds like the patient achieved MRD undetectable state. So again, I think this is the exact situation where we would be de-escalating the treatment, and I'm happy that he tolerated the glofitamab.
Before you get to John, is COPD on oxygen kind of a contraindication to CAR-T, Loretta?
I think that would be somebody I'd be very worried about, that they would have a hard time tolerating the CRS that can come with CAR-T. Again, you can quibble a little bit about Lysocell being probably the best tolerated CD19 auto CAR in this setting, but I would be a little nervous about that. But I'd be a little nervous about him tolerating glofitamab as well.
John?
I just want to ask the group, what do people think about this regimen, using it prior to an auto transplant in a patient who's transplant eligible? Have you used that? We've occasionally used this, and it seems like that may make sense for some patients.
Matt?
I've used Glofit plus ICE. I haven't used Gemox. I think that I've been generally dissatisfied with Gemox as a program in transplant-eligible patients, but I think that there's a very clear rationale for bispecific plus platinum in that increasingly narrow subset of patients that we're planning a consolidative auto-transplant for.
Just a question for my colleagues. If you obtain a complete metabolic response with Glofi or EPCO in patients who failed CAR-T, do you think it's correct to do a consolidation with allo stem cell transplantation?
How would you answer that, Pier?
Yeah. Good work. I mean, in high-risk patients, for sure. I will do after when I obtain a complete metabolic response after 3-4 cycles of Glofi or EPCO, I will move to allo stem cell transplantation as a consolidation.
So, Nancy, agree or disagree? And also, can you look into your crystal ball and tell us where bispecific is going to be fitting in 3 to 5 years with diffuse large B-cell?
Yeah, so in terms of the other situation, I guess it depends on if the patient was refractory initially to a chemotherapy regimen and then got a CR with Glofit or EPCO, I probably wouldn't be transplanting that patient because we know that probably transplant doesn't add anything to someone who's chemo refractory. I agree with doing the combinations. We actually had a trial open that we just completed with Mosun and either physician choice of ICE or DAX, and had very high CR rates, and that was specifically for patients who were going on to auto stem cell transplant, and that was very well tolerated before that. So I think it's doable. And then where we're going to be in 3 to 5 years, I think, again, as I think John was the one who pointed out, or Matt, that I mean, we need clinical trials comparing these really effective treatments head to head, because otherwise we're all just going to be making sort of our, gut feeling about which one you should do first, because the numbers look very similar and the patient populations are not identical. So, I mean, I think the Gemox, Glofit, those are presumably worse patients. Many of them had CAR-T, and also, they're generally older and they can't be eligible for a stem cell transplant. So looking at those results in a group of patients who potentially were worse even than the CAR patients, I think is very interesting. And I do think it's going to be the combinations, whether it's going to be an ADC plus Glofit. I mean, I think the Lonca Glofit looks spectacular with 9-month follow-up. We'll see where it goes from that. But I think that's what we're looking at is combinations. And I wouldn't be hesitant to, if that holds up, I would not be hesitant at all to use Glofit Lonca before CAR. Yeah.
All right, so we'll finish out here, bispecifics and FL, marginal, and MCL.
Thank you. Nancy did a very nice job kind of highlighting some of the key differences and unique aspects of the CD20, CD3 bispecifics, so I won't belabor, but I'll just maybe add that epcoritamab's label was recently expanded to include an addition of R² in second line or later follicular lymphoma. So you'll see an update at this meeting of the mosunetuzumab single agent data. This was in relapsed refractory follicular lymphoma in that third line or later space. And as Nancy alluded to, we see similar sort of stories play out in follicular lymphoma in that about 24-month median PFS. But as we get longer and longer follow-up, that median duration of response keeps getting longer. And this is a fixed duration. So again, somewhat response adapted, whether they had 8 cycles or 17, but to me looks quite promising. The toxicity, in my opinion, with mosunetuzumab is quite favorable and lends itself well to outpatient management. And you can see here that most of the toxicity is going to occur during cycle 1, and actually most of it's going to be grade 1. So these are unique toxicities, and it does require some educational component as we try to get more access for patients in community settings, but recognizing that about a quarter patients are also going to have grade 3 or higher neutropenia. So outside of CRS, that's mostly in the initial phase of this treatment, cytopenias, infections, becomes a later phase toxicity that you need to monitor for. And I already alluded, we'll see longer follow-up presented at this meeting. Epcoritamab is also approved in that third line or later setting as a single agent based off of this study. Again, comparable patient population in that these were mostly third line, over-enriched for patients that were either refractory to chemo and CD20 and a good proportion of patients that were POD24. As I've mentioned, if you achieve a complete response, that's much more durable, and I'm much more optimistic. Now, the difference in follicular as opposed to large cell lymphoma, we probably weigh the toxicity of a regimen equally to the efficacy. But again, if you can achieve a complete response with these agents, I'm going to be quite optimistic. Now, the key difference in this study is these patients were dosed until progression or intolerance, but similar to what we see with mosunetuzumab, most of the CRS is going to be low grade, and the vast majority of it's going to happen during the first cycle. The median time to onset of CRS is important because most of these patients, in my opinion, could be managed outpatient, but they're going to have that first fever about 20 hours in, and so these are going to be patients that are going to be home. So educating the caregiver and the patient about the toxicity to monitor for and how to manage it so that you could potentially prevent a hospitalization, I think, is critically important. Outside of CRS, this is a sub-Q injection, so you do see some local irritation of the skin. And so again, another potential area for education, but it's quite well managed. And again, you see about 13% of patients that are going to have neutropenia that's grade 3 or higher. There was an optimization of the dosing with an additional step-up dosing that did further mitigate the CRS. And so again, what we're hoping for is mostly grade 1 CRS, because the grade 2 is going to indicate that a patient's going to need either oxygen support, IV fluids, and or pressors. And so those are patients that are going to be transitioning from outpatient to inpatient. So anything that can be done to mitigate that, I think, is a win for patients. Now, I alluded to this. We will see the results of this randomized phase 3 study. This was in second line or later follicular lymphoma, looking at epcoritamab in combination with lenalidomide and rituximab. And Nancy mentioned, because of the epitope, there is potentially some additive activity by combining rituximab with epcoritamab. This was a fixed duration of 12 cycles, and it was compared to lenalidomide rituximab. So again, we'll see the full results, but it did meet its primary endpoint of a significant improvement in progression-free survival among those patients who received epcoritamab in combination with R-squared, and that led to the expansion of the label to include second line in combination. There is a sort of complementary study with mosunetuzumab in combination with lenalidomide. You don't have the rituximab component versus R-squared, again, fixed duration of treatment. And so we don't have the results of this randomized phase 3 that's an international study, but what we will hear about at ASH this year, there was an additional cohort of patients just enrolled in the U.S., and so 54 patients were exposed to mosun and lenalidomide, non-randomized. But what we can conclude from this is this does appear to be an effective and a safe regimen. So the challenge will be, if both studies are positive trials, how will you choose? You're going to have a triplet versus a doublet, and so we'll try to parse that out, but without a head-to-head comparison, that's going to be a challenge. Odronextamab is not approved in the U.S., but approved in the EU. And again, this is their single-arm phase 2 data, again, in a similar third-line or later space. And what you can see here, common theme, if you achieve a complete response, that's going to be much more durable than if you fail to achieve a complete response. And though in the past we've been very satisfied with the partial response because of the number of agents, and I'm going to move into some combination strategies, I do think we should be striving for a complete response in these patients. This was dosed until progression or intolerance. One of the newest agents that's going to be presented, follow-up data at this meeting, is a CD3 bispecific antibody. The phase 1, they did undergo a step-up dosing and some dose optimization in a sense, in that they had a 2-step-up dosing, and you're going to see data here. So it's a different target. It's an IV formulation. This was also in relapsed refractory follicular lymphoma, mostly in that third line or later space. They actually had a median of 3 prior lines of treatment and pretty enriched, again, for those that were refractory to their last line of therapy, over half. And the response rates have been just phenomenal thus far. Again, it's a single-arm study. It's early preliminary data, but I think this is an agent to look out for. Again, here's some of the earlier data that's been presented. You'll see more mature, larger sample size presented at this meeting in an oral presentation, but we see very dramatic responses. So again, almost 100% complete response rate, but you're seeing responses very early, and they do have cell-free DNA assessment in this using the phase-seq assay, that most of the responses happen very quickly. So you'll see a nice spider plot, but I do think this is an agent with a different target that I think is something to keep an eye out for. What about moving these agents into earlier lines of therapy? So the Morning Sun, we've seen now at a few of these meetings looking at mosunetuzumab subcutaneous formulation in patients that were previously untreated follicular lymphoma. Most of these are going to go out to 17 cycles, so it's about a year of treatment. So relatively shorter than some of these agents that are mostly dosed for 2 years as they move into earlier lines. Again, relatively small sample size of 102 patients, relatively short follow-up, but that looks to be quite promising. And I think the most critical thing, if you move into earlier lines with potentially bulkier disease, less heavily pretreated patients, you don't want to see any new safety signals. So this is a therapy that's been primarily explored in a community practice, in an outpatient setting. And when you look at this, again, without a head-to-head comparison, those rates of CRS, particularly during the first cycle, look to be quite favorable, and the vast majority are grade 1, which are generally manageable with acetaminophen. And so I am quite optimistic. Now, we'll have to pay attention to the infections and some of the serious toxicities as we get more patients exposed over time, but I do think this is very promising. There is a trial looking at epcoritamab with lenalidomide, no rituximab in untreated follicular lymphoma patients. And again, we've seen some preliminary data, but essentially we're going to be excited about all of these combinations as they move into earlier lines. And it's going to be very challenging without head-to-head comparisons to really navigate this. And we want to go head-to-head against our chemotherapy and have a 15-year follow-up study to really assess a difference in PFS. I think it's going to be a challenge to know or wait that long to really change practice, given most of these are going to be quite interesting studies. What about shifting gears to mantle cell lymphoma? So we do have single agent data with glofitamab, the 2-to-1 CD20, CD3, with a lead-in with obinutuzumab. They looked at 2 different dosing strategies with obinutuzumab, so potentially more circulation of tumor cells in mantle cell lymphoma. A lot of these patients have leukemia phase, splenomegaly, look a lot like CLL. And so strategies employed to try to mitigate that CRS that you might see. Again, with single agent glofitamab data, we see quite promising PFS and overall survival, kind of independent of whether or not they'd had a prior BTK inhibitor or not. Relatively small sample size with only 61 patients. CRS is going to be one of the most common toxicities you see, followed by cytopenias and then risk of infection. I do think it will be a little challenging to figure out where this fits into the treatment landscape, as mantle cell lymphoma is probably even a little bit more heterogeneous in a way than follicular lymphoma in terms of how it's approached in the US, but I do think this is an effective strategy. And similarly, we see combination strategies such as mosunetuzumab and polatuzumab in relapsed refractory mantle cell lymphoma that may be a more outpatient community practice friendly approach, similar to what we've seen in large cell lymphoma. This looks to be quite effective and quite manageable in terms of no new safety signals seen in a different B-cell lymphoma histology. This is the median PFS and overall survival. Again, relatively small sample size of 20 patients, preliminary data, but again, looks promising nonetheless. So there is a randomized phase 3 looking at glofitamab versus investigator's choice, and you have your option between BR and R squared. Again, maybe not the most exciting choices for standard of care, but a randomized study in a rare disease type, which I think is critically important. And then lastly, I'll talk about odronextamab in relapsed refractory marginal zone lymphoma, indolent lymphoma subtype that's been relatively ignored with all these agents, in my opinion. And I've showed you data with odronextamab in relapsed refractory follicular lymphoma, and very similar step-up dosing to try and mitigate some of the toxicity. What I'm showing here is PFS and overall survival broken down by subtype of marginal zone lymphoma. So I've been showing you a lot of outcomes based off of response, but this is looking at overall in the darkest line, and then you've got the extranodal in green and the nodal in blue, and then the splenic. And you do see kind of, again, very small sample size, but there is something kind of intriguing that the responses may be different depending on the type of marginal zone lymphoma you're treating. But it's good to see that there is clearly efficacy here. Again, no new safety signals. CRS tends to be one of the more common toxicities observed, but very manageable. And then that's followed by cytopenias and then relatively easy to manage non-hematologic toxicities. So in summary, I am very optimistic about CD20 bispecific antibodies in follicular lymphoma. I think it's less clear to me that you absolutely have to have a combination partner. Most of your combination partners are going to be lenalidomide based as of right now. And so it is going to be challenging as we have more readouts of these trials to navigate this, given we probably have more treatment options than patients with follicular lymphoma in need of treatment. But nonetheless, these are effective and manageable toxicities. And so we have to figure out how to get them into the community where a lot of these patients are currently being treated.
All right, thank you. So, Matt, I'd like you to listen to this case of a 54-year-old woman that Dr. Kusulu took care of, multi-regiment refractory relapse FL, who gets mosunetuzumab.
She developed progression of disease with neck pain and B symptoms. Biopsy showed low-grade follicular lymphoma, and at that time, I elected to treat her with mosunetuzumab. She did great with it, time-limited therapy, and she had a PET CR. She's doing fine, and we're seeing her every couple of months.
Any questions for the faculty?
Do you tend to go to CAR T-cell therapy at this juncture for someone her age, or would you go with a bispecific or a clinical trial? There's other options. There's EZH2 inhibitors. There's zanubrutinib, obinutuzumab. In her case, I chose this time-limited and also someone who has few comorbidities, not high-risk disease, so I chose that for her for those reasons. I'd like to know what's the utilization of bispecifics in the community for patients with follicular lymphoma who have several treatment options available to them. In some of our community practices, bispecific antibodies are not administered due to the concern for CRS. And so we may initiate that, and then once they're past their step-up dosing, then we would give them back to the community provider to continue with treatment. I'd like to know what your approach is for patients with bispecifics.
So, Matt, any comments in terms of sequencing of bispecifics and follicular, particularly also the issue of CAR T and follicular, where that fits in? And can a community-based general medical oncologist start any of these bispecifics?
Very important questions. So you heard from us that in large cell lymphoma, we continue to try to prioritize CAR T-cell therapy when we can because of proven curative potential. In follicular lymphoma, many of us sort of see a different argument there. And in FL, as Loretta put earlier, we really are equally weighing efficacy and toxicity in the patient journey. And in the absence of proven curative potential of either of these approaches, many of us prioritize a bispecific antibody in patients who have indolent disease without evidence clinically or histopathologically of transformation, trusting mosunetuzumab or your bispecific of preference, and oftentimes deferring CAR T-cell therapy for transformed patients or for patients who have been failed by a bispecific antibody. In terms of community administration, mosunetuzumab is perhaps most uniquely situated for wide deployment in a variety of healthcare settings. I have the privilege of working at a hospital health system where we have 13 hospitals, and we're seeing over the last year or two the ability across a health system to not just continue treatments after they've been initiated at an academic center of excellence, but to do those initial step-up dosing. And it's easiest with Mosun, in my opinion, because of these very low rates, not of grade 3+, but of grade 2+. And if you can really limit toxicity to grade 1, educate your oncologists and your patients, at-home dexamethasone at the onset of first fever, follow-ups with nursing staff and other colleagues, you can really do this in almost any healthcare setting safely and effectively.
What about access to tocilizumab in community practice? Do they need to have access? Do they need it in their office? Can it be a nearby ER or tertiary center?
Yeah. I mean, the good news is that many of us have toci around, left over from COVID or whatnot. Yes, there are requirements of having 2 doses on site, but if you're only using mosunetuzumab, those doses will get pretty dusty. Mm-hmm. And you can get very comfortable using this medicine safely, fully as an outpatient in the majority of patients.
So one more case, but just to get back to you, Matt, can you kind of provide a little bit of an overview of some of the infectious complications that you see? Again, thinking about community practice, what do community docs need to be thinking about over what time period, what types of infections?
Yeah. So you saw some of the sometimes chilling data about infections. I think it's a little bit unfair to poor old Odro. The numbers look worse. Even though Odro is the last to get its U.S. approval, it was the first out of the block, and they took a lot of the headwinds in the face as we learned about some of these challenges that led to perhaps exaggerated rates of toxicity. We know a lot more now than we did then. The infectious complications really result from B-cell lymphodepletion. So we can see cytopenias, certainly, and neutropenia can be common. You can give these patients growth factor to support them through treatment safely. But hypogammaglobulinemia is a frequent occurrence and can be associated with prolonged exposure. Unlike the paradigm with rituximab-based chemotherapy where we don't use IVIG prophylactically, we wait for patients often to have recurrent sinopulmonary infections before we intervene. We're increasingly comfortable in following the lead of our myeloma colleagues and earlier intervention with IVIG in the context of hypogammaglobulinemia, not waiting for the infections to arise. And when we do that, we see these medicines better tolerated.
Very interesting. All right, John, one more case from Laurie Sen, a 78-year-old man, again, multi-regimen refractory FL, gets mosunetuzumab.
He was quite symptomatically unwell at this point, but, he was lucky that we actually had, one of the earlier mosunetuzumab trials available for him that time. And he actually responded tremendously, got a complete response after only 2 cycles. And based on how that agent is delivered and how the clinical trial was designed, because he had a CR, completed treatment with 8 cycles only, and he now remains in remission 4 years later. He was probably the first patient that really made me recognize how significant bispecific antibodies were likely to become for follicular lymphoma. Because again, this was a patient who had very refractory disease. But, it does raise the question in, a patient who's maybe less clinically unwell, how do you choose right now between CAR T-cell therapy and a bispecific antibody for follicular lymphoma? Is there an optimal sequence? What guides you to choosing one versus the other?
4 years of a CR on this bispecific sounds pretty good to me.
So I think patients who achieve a complete response, many of them can show really remarkable durability of bispecifics. I'm a little bit concerned about the infections that we're seeing, with ongoing bispecifics and delayed from bispecifics. So I think if you're going to use a bispecific, I would strongly favor truncating it and keeping it finite. But, I think they've really shown to be very effective options.
John, any thoughts? And also, any thoughts about the SWOG study comparing mosunetuzumab to rituximab in low tumor burden FL?
Yeah, so I think that pretty much to answer the first question that Laurie poses, I think pretty much I would not use CAR T before bispecific. I think everybody's going to get a bispecific first, and with some of the regimens that are being developed, that'll be even earlier in the course of the disease. I think that mosunetuzumab will beat rituximab in the SWOG 2308 study. I think it'll be more toxic because it's a more toxic drug. That doesn't mean it's not tolerable. And I think we'll have to balance the efficacy and safety. I think it'll be very interesting, using a bispecific up front when you've got more T cells and better T cells, and how much that difference will be very interesting.
Any thoughts about what kind of infectious issues are going to come up in that trial?
There'll be more with mosunetuzumab than rituximab, I would bet. But all of the data that we have with both bispecifics and CAR T are in multiply pretreated patients who, a lot of the follicular patients will have had bendamustine and other things in the past, rituximab as well in the past. So, my hope is it won't be that bad.
So, final question to Loretta again, thinking about 3 to 5 years from now, where do you see bispecifics in FL?
Obviously, I'd like to see them move into earlier lines of therapy for the points that John alluded to, but I think the challenge is I kind of foresee a disparate approach, whether you're treating in an academic setting versus a community setting. I have to acknowledge, as much as I don't like bendamustine, it has a relatively ease of use component to it, and it clearly is effective. And so in 5 years, I still think most people in the community are going to be giving BR, and I think that most people in an academic setting is going to be putting patients on their favorite trial of the day. What I would really like to see is a better risk stratifying tool for follicular lymphoma, so we know who warrants something very novel that may be a little bit higher pain for the person prescribing it, as opposed to just throwing BR at everybody and then see what happens to those patients down the line.
So I want to thank the faculty and also the 3 docs, Drs. Casulo, Lunning, and Sen, for working with me to try to prepare this. Thank you for attending. Have a great night. Thank you so much.